they kind of had an agenda. And so sometimes that would turn me off. If they were very anti-OB, it's hard to sometimes get over that hurdle to listen. It's hard to not kind of close off immediately, you know? And one of the things that I loved about your articles is that I just felt like this is just evidence. And it's not with an agenda. It's not trying to tell someone what they should or shouldn't do. It's giving you real evidence so that you can understand where we're getting the information, why we're recommending something, why we're saying this might be a better idea than something else, or are they both equally valid? And there were so many things that even in residency, I had no idea why I did them. We were just taught to do them. And it just opened my world. And I just started reading. I was on fire, and I just started reading and reading and reading. And, you know, some of the things solidified what I did. Some of the things opened my mind and said, oh, maybe I can be open to something else. But now at least I have the background and really the evidence to say why I'm making recommendations. And you know, before that, I think the way I would counsel patients would maybe ring a little bit hollow and be kind of, well, because it's better, or, you know, because there's less risk of infection, you know, but really getting the evidence and seeing numbers and comparing and seeing why different, and also the comparing, I loved how you compare different bodies of work. So, you know, you have the ACOG, which is, you know, our American College for Evidence for OB, but then you also looked at, you know, in Australia and Britain and what other places say and what their practices are. And so that was really, I think, a big turning point for me. And this was actually when I was out of private practice already as a laborist here in in Maryland. And I just couldn't get enough. So I don't remember the exact way I found you, but I remember when I did, it was life-changing.
Well, that's amazing. Thank you for sharing that. I'm also curious about, you know, you've mentioned a couple of times you had a personal journey. I know you reached out to me after listening to Isis Rose on the podcast when she talked about home birth in the Black community, and you said you were blown away by her talk. You know, tell us about like how that or why that struck a chord with you.
So I went back and looked at when I listened to it. And so it was broadcast, let's see, on June 10th, and I had just delivered my daughter on June 6th. So I think that's one of the reasons I was in this emotional space. I just had my daughter, my second child, and I had a home birth. And I just thought it was really great how she spoke about everything that had been going on given the current you know, just social atmosphere right now in this country, and statistics coming out and really putting a flashlight on what's going on, not only in maternity and neonatal outcomes in this country, but for Black women. And, you know, that people aren't just afraid of going to the hospital because of, you know, their feelings and, you know, what they want their birth plan to be. But some of these women are really terrified that they, you know, could die in their hospital, or how they'll be treated, or how they'll be ignored, or how their children will be treated. And these concerns are justified. And so I just thought it was really special how she's shining a light on these stories, you know, through her site, and really trying to normalize this in the Black community and say, hey, this can be an option for some women, not for everyone, but this really can be an option, and let's dispel some of the myths. Along with her, I loved listening to, I think it was Jenny Joseph. Mm-hmm. I've heard a couple of times. And again, I just think just listening to them, it was kind of food for my soul, things that I couldn't articulate, but felt, and I could listen and say, yes, like, you know, that's amazing. Mm-hmm. So I think that I was just really impressed by the work that she's doing to help solve this problem of maternal morbidity and mortality in this country, and the disparities that Black women have.
Yeah, Jenny Joseph's talk was just like, yeah, it was amazing. So you mentioned you had a home birth, kind of like, you know, as a side, I had a home birth, but that, you know, you don't meet that many OBs who have a home birth. So why did you choose that? This was for your second child, I'm assuming, not your first.
Correct. So it is funny. I mean, if you had asked me 8 years ago, I mean, it's funny. I remember a colleague of mine, it must have been in 2017. So, you know, 3 years ago, and her brother and sister-in-law told her that they were going to have a home birth. And her and I got together to try to figure out a way to convince her that this was the worst thing that she could ever do. It was the most unsafe thing she could ever choose. And, you know, why would you risk this? And it's just so funny, you know, just the difference time makes. So I talked a little bit about, my professional in this journey, and I had also watched the movie, and I kind of found the movie Why Not Home? And I think that was a real game changer for me. Like I said, a lot of um, books or documentaries out there, I do find that they are very kind of pro and agenda based, and they can kind of be isolating to the other side. And it's very easy as an OB to say, well, these people don't know what they're talking about. They don't know the risks. I know the risks. I work in the hospital. I see births. I'm at emergencies all the time. That's great that you want to feel special and, at peace, but that doesn't negate the risk that you're taking. And when I watched Why Not Home, which was specifically about OBs, family practice physicians, and labor and delivery nurses who all worked in a hospital themselves, they were all professionals working at the hospital, and they chose home births for themselves. I remember saying, wow, these are my peers. They have the same education I do. They have the same knowledge I do. They understand how birth can have complications. So what do they know that I don't, that they would make this decision, which I was entrenched and always trained was kind of absolutely no. And watching that, and again, getting real evidence instead of just anecdotal stories, or just hearing about the horror stories that, we did in residency, and always just hearing about how something can go wrong. And also, I had worked long enough in a hospital to know that the hospital is not a magical place that prevents any poor outcomes as well. And even giving the best care I can, things can go wrong. So I kind of had a little bit more of a mature viewpoint of, you're not comparing something that's risk-free to something that's inherently risky. You're comparing kind of apples and oranges, a different basket of benefits and risks. And I don't think we talk about enough of the risks that can be in the hospital as well. And so when that kind of started, I think, opening the door. And so I wound up meeting a home birth midwife in the area. A colleague in New York said, you have to meet this woman. She's in your area. You really should meet her. Her name was Mari Rothman. And I emailed her this really long kind of diarrhea of the mouth email explaining, why I wanted to meet with her and talk with her. And she was so gracious. And
were you pregnant at this point already, or were you?
I actually had my first already. And I think, I can share about my birth story, but I met with her, and I was just blown away by her. And she invited me to come into her community care and see the prenatal counseling she did, and to kind of see her care. And it was the first time I think that I've ever genuinely seen evidence-based, what you talk about, informing and consent with shared decision-making. And I think it was one of the first times I actually saw that. And I also saw that, she's not sitting there with herbs and spices hoping everything goes well. She had full state-of-the-art medical technology ready for disposal. She just had a little bit more prudence of when it's necessary, and that's the thing that I found amazing, is that, she and so many home birth providers and midwives, they have all of this experience, and they know how to use it. It's just, we don't need to use it for everyone. So my first birth was in a hospital. And as an OB, I kind of didn't have any particular thought. I really didn't even do prenatal care the first half of my pregnancy, because I, worked in an office. I just had all my labs done, and I would go to my ultrasound appointments, and I really would just go to the ones that were necessary, mainly for my husband, so that he could kind of feel part of the process. I kind of had the attitude of like, well, I know everything, and there's nothing really that they need to tell me, so I just need to do my tests to make sure that the baby's okay.
So you're kind of doing self-prenatal care.
Well, I would go for my checkups, but obviously not really with the intention that I was learning anything. It was more of just, okay, do my vitals, do
check
the labs
the box
that you
off.
need.
Yeah.
Check the box off, I know the ones that I need to show up for. And we actually moved from New York to Maryland in the middle of my pregnancy. And so for me as a controlling OB, that was really annoying, because at my hospital, I would know exactly what OB I wanted, exactly what nurse I would want. So all of a sudden now I was in, Maryland, and I didn't know who any of the providers were, and trying to kind of figure out how to go about that. And so we settled with a group that I really did like, and me and my husband connected with. And I was about 39 and a half weeks, and had actually a very fast delivery, especially for my first time. And I remember waking up in the middle of the night, kind of feeling a little bit uncomfortable, just couldn't sleep. Um, an hour later, my husband woke up looking for me. We kind of watched TV. I was just like, I just can't get comfortable. I'm not really, having any contractions. And 1 hour later, I was having contractions 1 minute apart. Um, my mom, who was there, we woke her up and she was like, this is how my birth was. We need to go. And, my OB mind was like, I cannot call my doctor and tell her I've had contractions for an hour. That is crazy. They're going to send me home. So I was very much in an OB mind of trying to, doctor myself. But sure enough, we got there and I was in labor and I didn't really have any preconceived notions about pain management or epidurals, but I kind of do remember the process just going very quickly. And I think I'd said I wanted an epidural, and then all of a sudden I got one, and they didn't think I would be able to, that I was definitely going that fast because it was my first baby. And my mom was trying to tell them she's going to go quickly, and they're like, no, this is her first baby. That's probably not the case. And, I got the epidural, and right after that, I was, 9 centimeters. But I did have a common kind of side effect where my blood pressure dropped very low. And so because of that, the heart rate of the baby dropped. And so it was very kind of this tense situation where the heart rate was dropping, and, they were just trying to move me all around to get that to respond and bringing up my blood pressure. And there was a moment where I remember as an OB, kind of my eyes were welling up, and, my husband was like, what's wrong? And I was like, I'm going to have a C-section. Like, I'm watching this tracing and I know what everyone's thinking, and I'm definitely in this OB mind. And I just remember kind of crying, and I couldn't explain it. I'm an OB. I do C-sections all the time. I had no, besides just the recovery being more difficult, I wasn't really clinging to any one way that, I wanted my birth to go. And I just remember feeling kind of just panicky and scared. And, my husband was like, it's okay. Everything's going to be okay. And, luckily I just went very quickly, which is not the norm for the first time. And, then they had me flipping over and pushing as hard as I could and as fast as I could. And it was kind of just felt like it was this race against time. Like, am I going to be able to push the baby out fast enough, or is the heart rate going to drop? And, I remember the charge nurse, or my husband remembers this. I was in my own world, but my husband says that the charge nurse came running in and saying, the OR's open. We need to get this baby out now. And just, this very stressful, environment. And I think that I think you mentioned this a little bit too. I was fortunate. I think that my OB was as patient as she was, that she really gave me time and kind of tried to keep everything as calm as possible to allow me to have, a vaginal delivery. But, I didn't have any, trauma, or, I thought my OB team was great. But, fast forward 2 years, kind of watching a different style of care, I really started to see that, it's just a different model of care, even with our prenatal appointments. When I would watch Mari do, one, in the home, they were hour-plus prenatal visits. In the community clinic setting, it was, 2+ hours, and all the things that they talked about in the holistic care. So I kind of joked, like, oh, if I ever have a second baby, maybe I'll think about a home birth. But I actually didn't think I would ever do it. And what changed for me, I think, was my younger brother suddenly and unexpectedly passed away last year. And he's my only biological sibling, and it was just extremely traumatizing for all of us. I was with him, and his wife and my parents. We were all together when we had to say goodbye to him. And it's funny. I remember the day they were taking him for organ donation surgery, because he just has an amazing heart, and he wanted to be an organ donor. And so the last time I got to see him before they took him for surgery, I went to my hotel room where we were staying and saw that I got my period. And that wound up being my, my last menstrual period, which they always ask you for pregnancy dating. Do you know when you're, are you sure of your LMP? And I'm like, in my mind, I'm like kind of laughing. Yes, I'm sure. Like I remember that moment. And so it was really tough. 2 weeks later, I found out I was pregnant while I was trying to deal with all of this. And, it's really tough trying to be excited and celebrate life at the same time that you're doing such grieving. And it was really hard. And the second that happened, there was no other question in my mind for me. I texted Mari and I was like, okay, when's my first visit? And I just knew I needed a different level of support. I needed whole person care. I needed to feel like a mom and not an OB. I needed not a 7-minute quick check-in. I wanted someone that was going to take care of me. And this whole process, because I knew it was going to be different and hard in a lot of different ways. And so I think the fact that I had already trusted her and knew her and had known her professionally for 2 years, the fact that I lived 5 minutes from my hospital, and the fact that I knew that I had, a pretty quick, easy first-time birth, it was just clear for me that this is what I wanted. And, as long as everything was safe, that I wasn't going to have it any other way. And, by this time, I just had realized that safety and an uplifting, positive experience do not have to be mutually exclusive. And I could resonate a little bit more after my first birth because I had a quote unquote, everything was fine delivery. But I could resonate with people that have that base of fear of something going wrong. I could understand now why when I would walk into a room and tell someone that I think we needed to do a C-section, why they would break down crying. And I could never understand that before. It's
really interesting that you had that gut reaction to thinking you were going to have a cesarean was tears. And it was almost like you said you didn't have a preference ahead of time, but that tells me that internally you did have a preference.
Yeah. And so, I think coming out of that, and again, I was fortunate that I didn't have anything that I could say, oh, I had this bad birth experience or this bad interactions. I mean, my OBs were great. And I think I have to commend my OB. Actually, I think someone else would have maybe rushed me to the OR and not have been patient. So, but I think it just changed my attitude a little bit. Instead of kind of feeling frustrated with people and saying, what's the big deal? Your baby's going to be healthy. Everything's fine. It happens. It really allowed me to empathize and I think just be a better provider. And so I went to Mari and I was like, yeah, let's go. Let's do it. I never, looked back. And
how did your daughter's birth go?
Oh, it was amazing. Now that I've seen both, it was really amazing. I mean, even with COVID, and that adds a whole other layer. We delivered, in COVID times. But, I went into labor. I called them. They were there. It was just, I had music playing. It was just calm. It was peaceful. My husband was there. My mom was there. My sister was taking photographs. And, I wasn't as fortunate as you. When I read your book and you said there was no pain, I can't quite say that. But it was totally different how I felt about it. There was no stress. There was no that internal fear or rush of something going wrong. It just felt kind of like where it was supposed to be. My mom was there showing me birth pictures of my brother and telling me over and over again stories of her birth experience with him, and we were looking at his photo albums while in between my contractions. I was moving around. I was just very comfortable and beautiful and healing.
I was going to say, did you feel a connection with your brother during that process?
I did. And yeah, I really did. And just, I felt safe. I didn't feel like I was giving up safety at all. I felt I was in excellent hands. I knew that if there was any issue that were to come up, they would not think twice about letting me know if something needed to change. And so I just felt that I could let go. I really felt that I didn't have to be the OB, and I could just let go and be the mom and birth this baby and give, I had just lost my sibling and now I was able to give my son a sibling. And it was extremely cathartic for me and it was healing in a way. And it was just something that I think allowed me to begin the process of healing. So, I mean, it was the most amazing thing I've ever experienced. And, never once, even with all the contractions, I never thought, oh, I wish I could have that epidural. It was more of just about like using and leaning on the support and the people that were there with me to, get through, each contraction one at a time. And I was actually, excited to meet our baby. And we actually didn't know the sex second time around. So that was really neat too. That when she came out and, I found out it was a girl. So it was really life-changing.
That's amazing. What are your hopes for the future of birth? Now that you're in the DC area and you've kind of experienced both models of care and you're in a leadership position, like what do you hope to see happen, maybe in the next 5 to 10 years in the DC area?
I really believe that there's no right way to birth, right? There's no right place. There's no right way. I mean, I work in a hospital. I'm very proud of deliveries and the work that we do in the hospital and helping women birth. And so I'm very proud of that. And so none of this is to say that, that's not a good place. It's more about, again, that circle model of allowing the woman and her family to really be in the middle of the circle and lead the care and really feel that she's listened to and supported. And so I really will just love to see this beautiful collaborative care of all providers, OBs and midwives, learning from each other, working together collegiately, having respect and support for each other, and not an either or, but kind of an and, like we have this and this and this, because everyone will want and need something different. I would love to see more support for physiological birth, but just support for not one particular type of birth, but just support for that woman. There are people that from home birth to medication to hospital birth to planned elective cesareans, there's all births and all of them should be positive and uplifting and safe. And I think that's what I would love to see, is that just learning that, again, every family and woman and what's important to her, that we have that respect and empathy and kindness. And I just think there's a lot that we can learn from each other, OBs and midwives. And I hate in this country sometimes a little bit of that dichotomy that's there and that wall that's there, and the either or mentality. And I would just love to really see it become this and mentality.
So you kind of hope to continue being that bridge builder between those different models.
And just, like you said, working within your sphere of influence versus your sphere of concern. So, where I am at my hospital, I'm excited every person I get to work with, every provider that I get to work with, and just really trying to bridge a gap and see where we can learn from each other and grow and just continue to give great care and just be a place where women can really come and get an excellent, safe care. And, like you said, even things don't always go as we plan or as we want, but people feel that they had a positive and uplifting experience when they feel that they were part of that decision making. And so that's what is really important to me, is learning how I can do that and how I can help that woman who may need to have interventions she wasn't expecting or wasn't planning on, and still make it a positive and really exciting time for her, where she can look back and say, that was the best day of my life. That was the best experience of my life, even if it didn't go exactly how she thought it would.
So just kind of sounds like also like being a role model for others and applying that kind of care, truly supportive care.
There's things that I discover like, oh, I didn't even realize I was doing that, and you just keep learning. And I look back sometimes at conversations I would have with people, and it's kind of like, oh, ouch, a little bit. But, you just keep going forward and just trying to learn from the past and learn from others, and just, doing the best I can to give care to those who that I work with.
So when we were planning this interview, Dr. Warmsley, you said you would have a question you wanted to ask me on air. So do you want to read me your question?
Yes. So like I said, I love reading your articles about the evidence-based birth, specifically about interventions, and being around midwives and working with midwives. And then after my own home birth, I realized that one of the things that I have seen as a common thread with midwifery-led births and I guess physiological birth is that after the delivery of the head, that there is a pause and even waiting for another contraction before you deliver the rest of the body. And I have to admit my ignorance and say I never even knew that this was a thing. In residency, once the head is delivered, we just pull the baby out. And, we learn how to do that and, allowing for the which way the head is going to go and to go with the position of the baby. But you definitely don't wait. In fact, there's kind of this mad rush to get the baby out as quickly as possible, because there's this idea that the longer the baby is head out, body in, that, bad things can happen. Or with shoulder dystocias, we're taught that the length of time, obviously, of the dystocia increases the risk for baby. So there's this idea that once the head comes out, the body comes out immediately. And I'd never even heard of the fact that you can pause or wait or, for any amount of time or another contraction. And so I was curious from a evidence-based perspective, kind of where that comes from and what the evidence says about it.
I'm so glad you sent me this question ahead of time so that we had time to research it, because I don't know this off the top of my head. But Anna Bertoni, our research editor at EBB, did a thorough literature review just for you, but we can share it with everybody else, and I hope you can take it back to your department. So there is a paper by Kotaska and Campbell published in 2014, and they talk about how there's this common belief in OB-GYN that the longer head to body delivery intervals increase the risk of harm of babies. So like you said, in most OBs, after the baby's head is born, the providers will, they call it, quote, worry and hurry, pulling on the head gently but urgently to try and cause the birth of the rest of the baby's body without waiting for another contraction to occur. And this is called one-step delivery. And the reason for this belief comes from two studies published in the 1970s by a researcher named Wood. They found a statistically significant decrease in cord pH with increasing duration of head-to-body delivery interval. However, there's other researchers that argued that although there was a correlation between cord pH and longer head-to-body delivery intervals, that this was not clinically significant results in the studies. The first study only had 46 people, and the second study only had 22 people. And they were comparing like a normal birth to a fast birth, where they like hastened the birth by doing a quick episiotomy and quickly pulling the baby out using forceps if necessary. And because of those two studies with a total of just 88 people, they suggested that there was an upper limit of 40 seconds for the body to be born following the head as ideal to increase the cord blood pH. Obviously, that's not very good research evidence, and it's a very small sample study and not really clinically significant results, even though they found statistically significant results. In contrast, you mentioned how the midwives in your community use a two-step delivery method. This is what you see in normal physiologic birth. When the baby's head is born, there's a pause, and then the rest of the baby is born with the next contraction. It's also called two-step birth. And without any intervention, the baby's shoulders and trunk are not often born with the same contraction as the head. And so it's really common in midwifery practice to use the two-step method. We do have recent evidence that suggests that the two-step method does not increase the risk of harm and may even lower the risk of shoulder dystocia. In fact, researchers now think that speeding up the birth with gentle pulling before the next contraction could be partly responsible for the increasing rate of shoulder dystocia that we've seen in hospitals across the United States. And they think that resting between contractions gives times for the baby's shoulders to spontaneously rotate and orient themselves in the best position for the birth. Also, they say that in the one-step method, manually pulling the baby out without a uterine contraction, so say the mother's not having a contraction in that moment, can stretch the baby's shoulder, which can lead to a clavicle fracture or permanent brachial injuries. That was proposed in a paper published in 2020 by Hishikawa. We found one recent randomized controlled trial on this topic. It was published by Zhang in 2017, and they had more than 600 birthing people at 4 hospitals in China. So there were participants who were planning a vaginal birth, and they were randomly assigned to one of two groups. Either they got the one-step method, which you described, is common in OB practice, or the two-step method, where you wait for at least one contraction after the head is born for the shoulders to be born without intervention. And the results showed that the two-step delivery group had a significantly lower rate of shoulder dystocia than the one-step group, and no increase in birth asphyxia, which is kind of like low oxygen in the baby, or postpartum hemorrhage. More specifically, they had 4 cases of shoulder dystocia in the one-step group and 0 in the two-step group. Average head-to-body delivery interval was only slightly longer in the two-step group, 59 seconds instead of 44 seconds. And they didn't see any link with that to asphyxia. So that was the 2017 randomized trial. And we also have a 2018 meta-analysis of prospective studies published by Huang, and they pooled the data from 7 high-quality prospective studies that involved more than 7,000 birthing people who had a vaginal birth with the one-step approach and more than 7,000 people who had the two-step approach. These were not necessarily randomized trials, but they were prospective observational studies. They found that the two-step group had a significantly lower risk of newborn asphyxia, cut the risk in half, and a lower risk of newborn clavicle fracture, there were only 4 in the two-step group, and there were 24 cases in the one-step group. They didn't have statistically significant difference in brachial plexus injury, but there was a trend towards more injuries with the one-step method. And they did not report specifically on shoulder dystocia because they think it's subjective and poorly defined. And they concluded, quote, the clinical value is high for the adoption of two-step method for better neonatal outcomes, end quote. And we talk about shoulder dystocia a lot in our Big Babies article, evidencebasebirth.com/bigbaby. But one of the main problems with that is that the definition is really subjective. So ACOG defines shoulder dystocia as, quote, a birth complication that requires additional maneuvers beyond gentle pulling to relieve impaction of the fetal shoulder, end quote. However, some researchers use a definition of a head to body interval of more than 60 seconds. And this definition is sometimes used in different hospitals and different research studies, but it should not be used as the definition because it wrongly classifies two-step births as shoulder dystocia when it's not. It's just the method of waiting for the shoulders to rotate and come out. And, a delay from an impacted fetal shoulder where the shoulder is really stuck is very different than a physiologic delay from pausing between contractions to wait. So we also found one more prospective study that was too recent to be in the meta-analysis. This was published by Hisakawa in 2020, and they had 262 low-risk birthing people who gave birth at a single birth center in Japan using the two-step method. And everybody had the two-step method and compared the group where it took 60 seconds or less or more than 60 seconds, just to try and look at the differences between the length of time. And they found that the average head-to-body delivery interval was 89 seconds in this group that everybody had the two-step method. And they reported that the umbilical artery pH tended to decrease with increasing head-to-body interval. However, there was almost no correlation, and the decline of the pH was only 0.01 for every additional minute. They found no difference in the rate of low APGAR scores at 1 or 5 minutes, and they had 0 cases of shoulder dystocia among the 262 people who had the two-step method. So basically, we found that the one-step method, applying gentle force on the baby's head to quickly hasten the birth of the body, is not supported by evidence and actually may cause harm by increasing shoulder dystocia and birth injuries to the baby. And the researchers now recommend that a head-to-body delivery interval of up to 4 minutes between contractions is common, safe, and may reduce the incidence of shoulder dystocia. No traction should be applied to the fetal head during this time. However, the Kotask and Kimball article from 2014 says that if fetal monitoring indicates fetal compromise, you'd want to do the expedited delivery with the one-step approach rather than the two-step approach. So, and again, just emphasizing that if the physiologic two-step delivery, the interval appears to be on average more than 60 seconds. So you can't say you had shoulder dystocia just because there's an interval of 60 seconds. And researchers think that after the delivery head, shoulder dystocia should only be diagnosed if the delivery of shoulder does not occur with maternal pushing efforts and possibly gentle traction that accompanies the next contraction. So that's kind of the research. It was kind of fascinating. What do you think after listening to that?
Yeah, it's amazing. Again, one of the things that you just, never even realized that there was another way to do it. And I think that just goes with the idea that we can just learn so much from each other, because it wasn't that I thought that two-step was wrong. I just genuinely did not know that it existed. So seeing now that, it actually might be causing more issues with shoulder dystocia makes me kind of take pause and say, hey, let me maybe start doing something more physiologic, and that may even reduce some poor outcomes.
Yeah, and it was interesting. I didn't see anything in there about the perineal tearing with the one-step versus two-step, but I remember being at a birth of a friend's baby, and they did not tear with the birth of the head, but then they did the one-step delivery where they, pulled on the head urgently to try and get the rest of the body to come out quickly. And the doula pointed out to me, she said, look, she's tearing right now, because she didn't tear when the head was born, but they rushed the shoulders out and it didn't give her time to stretch, if that makes sense. And she tore as the shoulders came out and had a second-degree tear with that, which I thought was interesting.
Well, it also makes sense that if there's restitution going on where the shoulders are really turning themselves without a contraction to find the best way out,
mm-hmm.
that, you would probably have better outcomes and easier delivery, less tearing, versus manually kind of forcing the shoulders to come out. And if it's not on an axis, that would be ideal. So intuitively, it does make sense. So yeah. I'm excited.
So I'm excited to, publish this podcast and get that information out here. And I've got this all written up in a Word document. So I'll send that to you and you can share it with your department if you want to email it out to them. So. Yeah.
I just think it's really important. I mean, even as women, some may choose wherever their birth setting is. Just in the, United States, the majority of our births are going to be in hospitals. So I think doing what we can to really kind of make that environment positive and uplifting and supportive and collaborative, I just think that's really the key. And I'm excited to be a part of that in any way I can.
Yeah, thank you so much, Dr. Warmsley, for coming on the podcast and sharing your story and your passion. It's really inspiring to hear you and to know that you're out there doing such good work. So we're really thankful for you.
Thank you. And thank you for your amazing articles. I have learned a lot.
Today's podcast was brought to you by the signature articles at Evidence-Based Birth. Did you know that we have more than 20 peer-reviewed articles summarizing the evidence on childbirth topics available for free at evidencebasedbirth.com? It takes 6 to 9 months on average for our research team to write an article from start to finish, and we then make those articles freely available to the public on our blog. Check out our topics ranging from advanced maternal age to circumcision, due dates, big babies, Pitocin, vitamin K, and more. Our mission is to get research evidence on childbirth into the hands of families and communities around the world. Just go to evidencebasedbirth.com, click on blog, and click on the filter to look at just the EBB signature articles.